Okay, I see that we're at about 20 participants and I haven't seen that number move in a minute. So I think we're going to go ahead and get started since we're at 5 after the hour. I want to welcome everybody. Again, this is the Rules Advisory Committee for the Healthcare Provider Incentive Program, Oregon Administrative Rule Revision for OARs 409-036. My name is Jill Boyd. I use she, her pronouns, and I'm the lead for the Healthcare Provider Incentive Program. And I'm joined today by my colleague, Alyssa Sloan, as well as Jamie Taylor. And then we also have our colleagues over at the Oregon Office of Rural Health. Bill Funder is also on the call as well, who works closely with our program, and we're happy to have them there. I wanted to review the agenda with you all today. We have a very busy schedule, so I'm hopeful we can get through the sections of the rule revisions that we wanted to get through today. For those of you who are just joining, please, we want to welcome you. Please put your name, pronouns, organization, and role in the chat. And then I'm going to go over just quickly the proposed purpose of the changes again, and then we'll get into a little brief slide deck for those of you that weren't part of the rule revision, the RAC meeting 2 weeks ago before the Thanksgiving holiday, uh, just as a brief reminder of what we're here to do today. So the purpose of this rule change, this event is rulemaking for the Healthcare Provider Incentive Program, which was established under House Bill 3261 in 2017. The rulemaking process aims to update the incentive program descriptions based on recommendations and extensive review of the current rules by the Department of Justice through beginning in early 2024 into beginning part of 2025. The rule revisions will improve accessibility and clarity and understanding the incentive requirements, as well as reflecting on the current landscape of the healthcare workforce. Additionally, the revisions will embed stronger equity and inclusion language to better align with needs of the population served by this rule, including those in the healthcare workforce that deliver care to those experiencing the greatest inequities. This rule change is in direct alignment with the Oregon Health Authority equity goal. And then the sections that we're going to be reviewing today are sections about the Rural Medical Practitioners Insurance Subsidy Program, specifically the liability carrier participation, Section 5.5, eligibility criteria for the Community Workforce Assistance Grants, Section 6.0, review process for loan repayment subsidies and primary care loan forgiveness payments under Section 7.0, maximum award amounts, 8.0, transfer to provider service obligation to another site, 9.0, and suspension or waiver of minimum service obligations, Section 100. So we have quite a bit of things to get through today. If we don't get through all of them, we do have one more RAC scheduled for the beginning of January, since we have a lot of holidays in this month coming up that we want to make sure we don't lose participation because of those holidays. So we're going to have one more RAC scheduled to cover the rest of the rules if we don't get through them today. Jamie, if you want to switch over to the presentation slide real quick. Thank you very much. All right. So we're also going to talk a little bit about the what the purpose is of today. So here's some participation guidelines that we for those of you that haven't been to our RAC before, we're just going to go over quickly. We prefer that you raise your virtual hand if you'd like to speak. If you're using a desktop or mobile app, you can hand raising is in the reactions panel, usually with a little hand. If you're joining by phone, you can dial *9. We want to remind everyone that all opinions are valid. We prefer that there's no arguing or commenting on the validity of others' comments. We were really good about that last time. I'm sure we'll do just fine today. Opposition should be expressed without demeaning others. And then we also want to acknowledge and respect power differences. We don't all hold the same level of influence. Staff may call upon those who've not had an opportunity to speak to balance opportunity for input. And then, of course, we need to make sure we're respecting the time allotted on the agenda so we can get through everything we need to today. Next slide, please. Okay, as I mentioned before, I'm not going to go over these, but we have about 6 sections to go through, and then we'll do some wrap up and final comments. Next slide. And then what is the Rules Advisory Committee? For those of you that may be the first time sitting on one of these committees, the Rule Advisory Committee, or RAC, is part of the rulemaking process. And when possible, the Oregon Health Authority can appoint an advisory committee to help develop proposed rules. The advisory committee would include persons likely to be affected by the rules and would meet with the division to discuss and give feedback on the proposed rules. What the RAC includes is an overview or review of the draft rule language proposed by OHA. That's what we're doing today, and the opportunity for impacted parties to provide feedback or guidance on draft rules. What the RAC does not include is a discussion on the validity or the efficacy of the legislation or an opportunity to change the House bill. Next slide, please. So what is your role as a RAC participant? We encourage and hope you'll be able to provide feedback on the draft text proposed by the Oregon Health Authority, which we'll go over in a moment, offer suggestions as how to improve the implementation of the program as outlined in rule, and then please pay special attention to any industry jargon and identify where it does not align with your understanding. So we want to make sure we're not using that. Our goals for today, again, we're going to review the rule text sections that govern the Healthcare Provider Incentive Program, commonly known as HCPIP, because we are acronym heavy in the Oregon Health Authority. And the sections that we will be reviewed today, we've mentioned before, section 55 through 100. Again, we want to identify opportunities for clarity in verbiage to ensure shared understanding of HCPIP expectations, and then identify potential opportunities for improvement related to planned program implementation. And I think that is our slide deck for now. I think the remaining slides we'll talk about at the end. So if we want to go back and start at the redlined rules. Okay, here we go, everybody. We're going to jump right into it. Give me one moment to pull up all of my rules notes here so I don't lose my place. Okay. All right, thanks, Jamie. So we're going to start today with section 409-036-0055. This is actually a new section. Per the recommendation of our DOJ representative, she recommended that we pull out the medical professional liability carrier participation section from section 50, which we referenced at the last RAC, and it's directly above section 55. So if you recall from the last RAC, we reviewed the rule changes for the healthcare provider eligibility criteria. So this section is really meant to define, it's a new section to discuss the rural medical practitioner insurance subsidy program, medical professional liability carrier participation as well. So much of this language was pulled from section 50 and kind of put into a brand new section for ease of understanding and clarity. We wanted to make sure that the language was revised to align with the definitions that are outlined in the definition section 10. And let me see and make sure I have. So we'll go through these really, not real quick, we'll go as fast as we need to go. So the carrier participation to participate in the medical professional liability insurance premium subsidy program outlined in 409-036-50, a carrier must certify that it is authorized to issue professional liability insurance policies or certificates in Oregon. In order to do that, they must provide written certification to the authority no more than 30 days prior to the beginning date of the calendar quarter in which the carrier will participate in the subsidy program, meaning that they can participate if they want to be a new carrier anytime during the year, but payments are made on a quarterly basis. So if they want to fall within that quarterly payments process, then they need to be able to provide written certification to the authority with enough time at the beginning of the calendar quarter. Certification that's required to be delivered to the authority is either by mail to the following address or by email to the provider incentives inbox. The certification must be signed by the individual authorized to represent the carrier, and the certification must comply that the carrier is an insurance company holding a valid certificate of authority from the Director of the Department of Consumer and Business Services, or DCBS, that authorizes the transaction of insurance as defined in statute 731.066 subsection 1 and 731.072 subsection 1, and does not include DCBS listed insurers pursuant to ORS 735.300 to 735.365 and ORS 735.400 to 735.495. Basically, those are confirming that surplus line carriers and excess line carriers are not eligible to participate in this program. Section B understands the authority may confirm the representation in paragraph A with DCBS, and that DCBS determination about whether the carrier holds a valid certificate of authority to engage in professional liability insurance in the state of Oregon and other criteria in paragraph A must be relied upon the authority in determining whether an insurer may participate in the subsidy program. And they agree to comply with the terms and conditions of the rules applicable to the subsidy program in effect at the time of initial certification for those rules in effect when any request for subsidy payment is submitted to the authority for payment. I'll pause there because that's a lot of language, a lot of words. So we'll let that sink in for just a moment. Thanks, Jamie, for moving up. So if a carrier does not provide a certification to the authority within the time established in subsection 1, the carrier may not submit a request for premium subsidy payment for the applicable calendar year. An eligible practitioner insured by the carrier may not receive the premium subsidy for that quarter. So we're not going to pay you if you don't submit the appropriate documentation to be deemed eligible. And a carrier must notify the authority in writing of any material change in any status or condition that relates to their eligibility to participate in the subsidy program. So for example, if they no longer hold a certificate of authority on file with DCBS, we need to be notified of that information because we don't reach out to DCBS to note of any of those changes. That's something that we rely on the carrier to do. One of the elements that we did add is subsection 2 on carrier discontinuation. Boy, apologies, my Friday brain is in full mode today. So this section is new. It's not pulled down from section 5.0, and this is stating that a carrier must notify the authority at least 90 days prior to the beginning date of the next calendar quarter if the carrier wants to discontinue participation in the program. The carrier must notify its insured eligible practitioners of its intent to discontinue to participate at least 60 days prior to the date of the next calendar quarter. We just don't want carriers to ghost us. So we felt that was important to include some information around carrier discontinuation as well. Moving on to subsection 3, each carrier participating in the program must electronically, using some sort of Microsoft Excel or spreadsheet application, submit a report to the authority within 30 days after the end of each billing period, either monthly or quarterly, showing the following information for each eligible practitioner who has been determined eligible for a premium subsidy as of the end of the billing quarter. This report must be delivered to the authority by email to the provider incentives email, and it must include the following. We want to see the carrier's name, the practitioner's name, who is being covered under the carrier's insurance. And for each practitioner, we have a list of things that has not changed. We need to know their license number. We want to know their specialty and their specialty class so that we can make sure that they're being reimbursed at the proper percentage rate. practitioner specialty, or excuse me, insurance service office code, policy number and effective dates, billing period cover start and end dates, billing frequency, if they're billing on a monthly basis or annual, quarterly, or monthly basis, current in-force annual premium coverage for limits. We do a 1 million per occurrence up to 3 million annual aggregate. Premium subsidy percentage calculated in accordance with section 80, which we'll get to in a little bit. Dollar amount of the premium subsidy calculated in accordance with section 80, subsection 3, which we'll get to. Explanation of any adjustment under this program from previous reports. So if there was a miscalculation from the previous quarter and there's a reduction or addition in that amount, that can be included and needs to be explained in those adjustments. Policy coverage limits, claims made step of practitioner if applicable, and identify practitioners who were not on the eligible list at the beginning of the quarter. Annually, a copy of the base rates and increased limit factors table is also something that needs to be included. Carriers must notify the authority if there's any change to the current base rates and increased limit factors table within 30 days of the change. Section 4 talks about failure to make any timely submissions under subsection 3 could result in a delay in processing or declining a payment request. We could do either. We've not ever declined a payment request, but definitely delays can occur if we do not receive submissions in a timely manner. Subsection 5, the authority will calculate the payment of premium subsidies from the Rural Medical Liability Subsidy Fund based on the funds available for the applicable billing period. A carrier must reduce the premium charged to an eligible practitioner by the amount of any premium subsidy paid or to be paid under the program. And then unfortunately, if there are insufficient funds to provide to the maximum premium subsidy to all eligible practitioners, the authority may reduce or eliminate subsidies for eligible practitioners in an equitable manner and will notify affected carriers and eligible practitioners. In the event of insufficient funds, the risk of the carrier delay in submission of a request for subsidy payment is on the carrier because payments will be based on the subsidy requests received timely for each applicable billing period. All right. Our last little section here, each carrier participating in the program must provide its insured eligible practitioners with the following information quarterly with each eligible practitioner's billing statement. So we want to know the quarterly premium due before the premium subsidy is applied, the amount of the premium subsidy, and the premium after the premium subsidy is applied. So that was quite a mouthful. Again, not many of these rules have changed. We moved a significant chunk of that section from section 50 and created its own section and cleared it up for easier understanding of this of this section of the rule. So I'll stop there for comments if we have any. All right, not seeing any hands. I'm going to move into the new section. So this section is 409-036-0060. We have created a new section that is the eligibility criteria for community workforce assistance grants. So this section that was previously the participation and application requirements have been moved to different sections of the rule. Specifically for loan repayment and loan forgiveness. That language was moved up that we've already covered in the last RAC meeting. So we removed this section and we're creating a new section called 60, which refers to eligibility criteria for the community workforce assistance grants. If you remember back up in section 20, where the types of incentives offered under the program, we have them listed in order, beginning with loan repayment, loan forgiveness, SHOE, And then we talk about the rural medical malpractice insurance subsidy, which we just completed. And then now we're talking about the community workforce assistance grant. So we're trying to go in a little bit of sequential order for clarity of the rules. And this is all new language. This information was aside from what is in black, all of the green area is all new language for this section of rule. This section is new and includes eligibility criteria that outlines the process for the Healthy Oregon Workforce Training Opportunity or how-to grant process. But we wanted to make sure that it was also inclusive to other different types of incentive opportunities that fall within this Community Workforce Assistant Grant. So hopefully that makes some sense. The application cycle is determined by the authority. So the organizations in Oregon or the proposers may submit a proposal in response to a request for grant proposal, RFGP, or a request for grant application, RFGA, depending on what the type of assistant grant looks like. This is from the authority to expand health professional training within Oregon to address current and future shortages in the healthcare workforce. So this subsection 3 talks a little bit about the purpose of the Community Workforce Assistance Grants, which is intended to support innovative, transformative, and community-based training initiatives and expand health professional training within Oregon to address healthcare workforce shortages for people that are in the culturally and linguistically diverse groups that have been economically and socially marginalized, tribal communities, rural communities, communities experiencing inequities throughout Oregon. In order to be eligible for the Community Workforce Assistance Grants, proposers must be launching innovative training initiatives that address documented shortages in the areas outlined in Section 3. The authority accepts proposals from projects in all disciplines of the healthcare system. Proposals must be submitted to the authority in the form and manner identified by the authority in the RFGP or RFGA. The authority shall only consider timely and complete proposals for possible approvals and offering in the agreement. So no late work will be accepted. And it is within the authority's sole discretion to issue an RFGP or RFGA review and consider proposals submitted, set the time for submission of proposals, or extend the time for proposals, and to award grants that, in its best judgment, achieve the purposes of the RFGP or RFGA under ORS 676.454, these rules and other applicable law. So I'll stop there since this is a new section. If we have any comments about the language here. Do we define innovation? I think, that's something we can take into consideration if we need to define innovation. Thank you for that comment. What else am I seeing here? Is there a section who is eligible to be a proposer under this section? I think that's, yeah, something we may want to also look at since I'm not sure if we have proposer up in the definition section. Thank you for that comment, Mark. We'll take that into consideration as well. All right, any other comments on this section? I'm not seeing any hands raised. I'm not seeing anything else in the chat. We will make note of those comments. Thank you very much for reviewing that section. And with that, we're going to move into section 7.0, which is the review process for loan repayment subsidies and primary care loan forgiveness. So this is, again, we've modified this rule section to provide overall clarification of the application and review process, which was part of the old section 7.0, and we wanted to clearly outline the review process considerations. So we'll go through this as well. For section 1 and 2, we wanted to revise the review process language here. So section 1 says that this provision relates solely to the loan repayment subsidies under OAR section 3.0 and primary care loan forgiveness payments under section 3.6. So the review criteria is very similar for the two incentive opportunities. The authority may consider the following factors in determining whether to accept an eligible provider for participation in the program. Eligible providers who apply to practice at a qualified practice site must be located in a health professional shortage area or HPSA as defined by the Federal Health Resource and Service Administration. That F should probably be capitalized since that's a that's a name that has been determined to not reach the threshold for federal National Health Service Corps, NHSC, or Nurse Corps awards in a given year. Section B talks about eligible providers to apply to practice at a qualified practice site located in a service area ranking below the median of the most recent area of unmet healthcare need report published by the office, meaning the Office of Rural Health, and posted to the authority website and office website. Eligible providers, so that's section has also been added. So we have other ways for folks to see where the areas of unmet healthcare needs information is posted. Section C talks about eligible providers who will provide services in an affiliation with a patient-centered primary care home or PCPCH. We have the PCPCH program here within the Oregon Health Authority as recognized by the state of Oregon. We also take into consideration the physical location of eligible providers delivering telehealth services. We understand since COVID, and especially in rural and remote areas, that delivery of telehealth services is integral to meeting the needs of our vulnerable and medically underserved areas and patients. Eligible provider types, disciplines, or ethnic and linguistic diversity particularly needed in a community, including ethnicity, language spoken, specialty, or provider type. We also take into consideration a qualified practice site client demographic that represents a priority population in the area that they're serving. Upon approval of the application, the authority will enter into a contract with the eligible provider. The authority will disperse funds in accordance with this contract. Funds are not considered obligated and will not be transferred until all required contractual documents have been executed by the applicant and the authority designee. An eligible provider participating in the program may request to change their program award status from practicing full-time to practicing part-time at a maximum of 1 time per term in the contractual agreement. Providers can go from full-time to part-time, but they cannot go from part-time to full-time. So that's a one-time change. And that has been established in this rule previously as well. To request such change, an eligible provider must submit a completed request for program award status change. This information is available on the program website and submit to the provider incentives email address within 30 days of this change. If approved by the authority, the eligible provider's remaining disbursements under the contractual agreement will be reduced by half if they go from full-time to part-time, and the eligible provider will be required to enter into an amendment of the contract to reflect this change in status and updated disbursement terms. And I will stop there if anybody has any comments or questions. And I'm going to do a time check, Alyssa. How are we doing on time? I feel like we're rolling right through this. So,
yep, we're doing great. We're about 10 to 15 minutes ahead of schedule. So,
oh, excellent. Okay. All right. I'll give a few more minutes if anyone has any thoughts. If not, we can move into section 8.0. So again, all this language that's been redlined through has just been moved up into the new section 7.0. It's all the same language, so hopefully that's not confusing for everybody. Okay, so now we're going to talk a little bit about Section 80, which is the maximum award amounts. So we have these broken out into by incentive opportunity. So starting with the healthcare provider incentive program loan repayment subsidy recipients. Again, we were referencing the rule subsection or Section 30. They're eligible for maximum loan repayment award in the following manner. Um, so ineligible providers who practice full-time. So we wanted to include some clarifying language for full-time practice because this was a little bit confusing for a lot of people. So those with less than $29,000 in qualifying debt load are eligible to receive up to 100% of qualifying loan debt for an initial 3-year service obligation. We had stated that it's not to exceed the lesser of their total qualifying loan amount or $20,000. With the recommendation of our DOJ representative, have removed this section because if if there was an awardee that had $29,000 and $29,001, they would not qualify for that 100% of the less than, sorry, excuse me, less than $29,000. They would qualify up to 100% of loan debt. But if you have 29,001, you would not qualify for that 100% loan debt. So really, we wanted to make sure that this was clarified language. We also have added in the last program year additional disciplines with loan repayment program that have debt load that might qualify for that under $29,000, including dental assistants and dental therapists. And so we thought it made a lot more sense to remove this section of the not to exceed lesser of their total qualifying loans of $20,000, just for clarity and better understanding of what what's falling into what type of loan repayment category. I'm going to stop there because I feel like that was a little bit confusing. So if there's anybody that has questions on that. This is kind of confusing even when we go through it. So those that are participating with in 29,000 or more in qualifying loan debt are eligible to receive. So we do repay 70% of the balance owed on a qualifying loan upon program entry for initial 3 years of service. We would pay 80% of the balance owed on remaining qualifying loans for an additional 3 years of service, or we would pay 100% of the balance owed on remaining qualified loans for a final 3 years of service, but the participant may receive no more than $50,000 in a single year for full-time service. So that if you do the math, that's $150,000 for a 3-year service obligation. And you can have that $150,000 times 3 if you are awarded 3 times within this incentive opportunity with a 9-year service commitment. Is that enough math for a Friday morning? I'll pause there for a moment. All right, so those eligible providers that practice part-time with less than $15,000 in qualifying loan debt are eligible to receive up to 100% of qualifying loan debt for initial or subsequent service obligation. This language is similar. We wanted to include some clarifying language and remove that not to exceed the lesser of their total qualifying loan amount or $10,000. This again was quite confusing both to the program office as well as to our providers that were participating in the program. So we felt that it made a lot more sense to try to remove some of that language as well in alignment with what we decided to remove in the full-time section. And so for those with $15,000 or more in qualifying loan debt, they're eligible to receive 35% of the balance owed on qualifying loans upon program entry for an initial 3 years of service, 45% of the balance owed on remaining qualifying loans for an additional 3 years of service, or 50% of the balance owed on the remaining qualifying loans for a final 3 years of service. So again, they could apply and be awarded up for 9 years of service commitment, and the participant may receive no more than $25,000 in a single year for part-time service. So that's $150,000 cut in half for $75,000 within a 3-year service commitment. And you can take that $75,000 times 3 for a 9-year service commitment if they're awarded 3 times. And I'll stop there for a second for everybody to get their calculators out and do the math if they want to. Again, this language is not changing, anything around program requirements. We just wanted to make sure that the language was a little bit more clear for any providers that are interested in applying for this incentive obligation. All right, so we did add some language to the scholarship recipients under ORS 343.303, which is the SHOE, the Scholars for Healthy Oregon Initiative, and primary care loan forgiveness recipients under Section 3.5. They're eligible for incentives as follows. So we wanted to make sure we include the OAR references for the scholarship recipients and PCLF. And we did make sure that we wanted to include some additional semantic language. The scholarship recipients under SHOE shall receive a scholarship covering the entire cost of tuition and fees for the participants' healthcare education at the university. Eligible students, we did include that language, participating in educational or training programs other than those identified in Section 3. So those eligible students, for those of you who may not remember, in PCLF, they have to be part of a rural training track, an eligible rural training track such as AHEC Scholars or another rural training program that has been approved by the Oregon Health Authority. So that's what we're referring to in eligible student participation. This language is all the same. We didn't make any changes to that. We just added another clarifying word under the maximum scholarships for each eligible student do not exceed the highest resident tuition rate at a publicly funded health professional training programs in the state. Okay. Any questions on those changes? Pretty minor changes, not really changing any program information, just making some clarifying semantic language changes. And then for the insurance subsidy, we wanted to keep the titles consistent. So this is, again, is the rural medical practitioners insurance subsidy recipients under Section 5.0 shall receive a maximum subsidy. And we have that broken down by 80, 60, and 40%. And then those, and then 15% of the actual premium charged for everything that doesn't qualify in subsection A, B, and C. And then if we can scroll down just a little bit more, any other subsidies, we did include a little bit of clarifying language to include the Oregon administrative rules for reference with the other subsidies that we may provide the healthcare workforce scholarships under Section 4.0 and the community workforce assistance grants under Section 6.0 to an organization to support innovative or evidence-based practices for recruitment and retention of healthcare providers. So again, a minor clarifying change and inclusion of referencing the OARs in the above mentioned sections. So I'll stop there since we're at the end of another section. If there's any questions or comments in the chat. Okay. Rolling right through. I love it. So this section we did provide some changes to it that we wanted to go over. So this section 9.0 is transfer of provider service obligation to another site. So we wanted to be clear and be able to revise the language to provide clarifying, a little bit more clarifying language regarding the site transfer process for providers that are participating in one of our incentive opportunities that requires a service obligation. So we don't want to hold providers that are participating in one of our incentives to be obligated to stay at their site if for whatever reason they need to change to another site that's eligible within the state of Oregon. So in the event of a practice, we decided to use site closure instead of failure. I think that's just kind of language that's a little bit more, makes a little bit more sense because we don't really know what practice failure could look like, but we definitely know what a site closure would look like. So we decided to change that language or any other extenuating circumstances. Eligible providers may transfer the service obligation to another qualified practice site upon prior approval from the authority. A transfer without prior approval is considered a violation of the contract because we need to ensure that the site that they're going to is considered a qualified practice site. So we removed this language. I think it was a little, we didn't really need it. It was kind of uh, verbose, I suppose. And so we decided to take that out per recommendation of our DOJ agreement and instead include the statement that an eligible provider requesting transfer to another qualified practice site must submit a written transfer request to the office. So we have the Oregon Office of Rural Health accepts the transfer request within 30 days of the occurrence for submission, and then it's approved by the authority. And then these are the areas that we need to have documentation for so the authority can approve the site transfer. We need to understand the circumstances surrounding the need of transfer. So if a clinic is closing, obviously they can't work there anymore. They need to find a new qualified practice site. We can say clinic is closing, looking for finding a new practice site. Proposed new qualified practice site, so they do need to have a new practice site identified, the name of the director or administrator at the proposed new practice site, so we can contact them and make sure that they complete a site application to determine practice site eligibility. And the eligible provider must also submit a letter from the original practice site releasing the eligible provider from any employment contract, if applicable, and provide an explanation for the termination of employment. So this language is all the same. We didn't modify this language at all. But down in subsection B, an employment contract with a new qualified, we're using qualified versus qualifying practice site, a letter of intent to route from the new qualified practice site to employ the provider, documentation of the provider having established a sole proprietorship, LLC, limited liability partnership, or professional corporation. And that's extraneous information that we didn't need to include. And then we struck through a new practice site and collaboration with the provider. So we just said, you have to also submit a letter of support documenting the site meets the definition of qualified practice site. Confirm that the site will cooperate with the eligible provider to comply with the monitoring and follow-up requirements set forth in these rules and any other information requested by the authority. And an eligible provider's failure to obtain prior approval from the authority prior to transferring their service obligation to another site or failure to notify the authority upon termination of employment at practice site within 30 days of occurrence may be deemed in breach of their contract with the authority. And I see we have a hand raised, so I will stop there since we're at the end of our section. Courtney, go ahead.
Thanks, Jill. I just want to be clear because you have used the example of closure, but the purpose of the language change is that there could be numerous reasons for a need of a person to transfer to another facility or job location.
Correct. That's
as long as it's a legit, long as it's a place that is still qualifies, they follow these steps that the program their incentive should follow them.
Correct.
Okay.
Yeah. Not just a site closure. That's just, an example of one of the potentially extenuating circumstances.
Yes.
But I appreciate the comment for that because I can see how that could be confusing.
Well, I think it's not just closure. Sometimes now what we're seeing is people being bought by a different group, and maybe the provider doesn't want to work for that.
Sure. Yeah, again, this is not indentured servitude. We don't want,
Yeah.
we don't want to hold, providers, against their will if they're not in a good space. But we just want to make sure for clarity of the rule that they notify both the Office of Rural Health and approved by us if they do decide to make a practice site change. So we can determine that it's an eligible practice site that meets the criteria for sure. Yeah, thanks for that. Any other comments or questions? Okay. Are we at the last section that we're going to talk about today? Goodness. This is great. We might be able to go like we did at the last RAC and go into a couple other areas. So this section talks about suspension or waiver of a minimum service obligation. So we did make some changes to this and revise some of the language, and again, to provide clarifying language regarding temporary suspension for providers completing their required service obligation. We wanted to include some language to support clarification of what temporary suspension is. So trying to like revise some of the language to make it more clear. And then wanted to include some language to support the clarification of the waiver of service obligations. So if a provider has some sort of issue that they want to waive all of their service obligation, and then we can we'll talk a little bit about that. And then if there's any duplicitous language, we've stricken through that, we struck through that information if it seems duplicitous based on our conversations with our DOJ representative. So I'm going to go through these as well. So section 1, we removed during the time of suspension, awards shall be suspended. I think that seems a little bit duplicitous. We state that the authority may agree to suspend a participating provider's service obligation for a specified time under circumstances it deems appropriate, including but not limited to parental leave, medical leave, military service leave, or other factors beyond the provider's control. A participant requesting we wanted to include temporary suspension of minimum service obligation shall complete a request for temporary suspension of participation form located on the program website, that's citing the reasons for such requests and providing supporting documentation of the circumstances. The eligible provider must submit the written request to the office within 30 days of the occurrence for submission and approval by the authority. And then we talk a little bit down here about including some additional language to help support the process of the temporary suspension. The authority may temporarily suspend all or part of the provider's minimum service obligation as outlined in these rules and the provider's contract agreement with the authority under the following circumstances. If there is a removal from a qualified site due to unforeseen circumstances beyond the provider's control, parental leave, closure of a qualified site, or other unforeseen life event beyond the provider's control, and the provider agrees to execute a contract amendment reflecting the terms of suspension and updated incentives distribution or chart. The authority may waive all or part of the minimum service obligation. So if there's following circumstances. So if there's a death of the participant, obviously that participant can no longer fulfill the requirements of their minimum service obligation. But we would like to, the rules states that we want to have upon receipt of a copy of a valid death certificate or other written documentation acceptable to the authority. We don't want, I know it sounds crude, but we don't want anybody to fake their death in order to get out of a service obligation. So we do need to see some verification for that. Any medically verified total and permanent disability of the participant or other significant changes in life circumstance of the participant. And then we removed this information since the temporary suspension form clearly states above that we want to have some information around the reason for the temporary suspension. So we didn't feel like we needed to reiterate that information. And then we also removed subsection 4 about the imposing a penalty for failure to meet the obligation. We have a section about in section 120 about failure to comply, any penalties and appeals. So we decided to move that section to the appropriate section under penalties. And I'll stop there for any questions or comments around temporarily suspending service obligation for incentives. Okay. And I don't have the agenda up again, Alyssa. How much, we have about what, 15 more minutes, I think? Is that right?
Yes, that's correct.
Okay. So I think let's go ahead and go, if that works for everybody. That means we could possibly have a shorter RAC meeting in January. Let's go ahead and move into section 110. If that works for everybody, we'll just keep rolling on. This has been wonderful that we're not going over time. That's always a concern, right? So section 110 talks about monitoring and follow-up requirements. So we did again add some inclusion of clarification language to monitoring the requirements and follow-up communication and documentation that's required by the authority. So a lot of these are just clarifying syntax language. So to maintain participation in the program, which should have a capital P, an eligible provider must notify the authority immediately upon beginning work at a qualified practice site. We're keeping consistent language throughout the document. And submit semi-annual reports signed by the eligible provider and the administrator of the qualified practice site, verifying the eligible provider's employment or licensed business in the case of sole eligible providers. The semi-annual report must include site and eligible provider's caseload, panel size or equivalent, because we do want to make sure that they're providing the minimum requirement for direct patient care. Site and eligible providers Medicaid caseload and Medicare caseload so that we can determine that they're providing services under the qualified site requirements. Eligible provider full-time equivalent status, if they're full-time or part-time. Number of percentages of qualified practice site patients whose healthcare is covered by Medicaid and by Medicare, and the number of patients at the qualified site who are uninsured, and then any additional information requested by the authority. An eligible provider must submit the first annual semi-report 6 months after employment begins, and every 6 months thereafter until the term of the contract is complete. That sentence was a little confusing, so we tended to revise that for clarity. And an eligible provider participating in the capital P program that wishes to transfer the service obligation to another qualified practice site must follow the requirements listed above in section 90 and the terms of any contract with the authority. So that's just providing a little additional language about wanting to move into a different practice or needs to abide by those rules listed above. So again, not changing any kind of programmatic design, just merely trying to provide some clarity to the language provided in this rule. Do we have any questions or comments for this? Okay. Let's move into section 120, if that works for everyone. All right, so this talks about any failure to comply, penalties and appeals. So again, we provided including some more specific language on when to standardize non-compliance parameters and clarify OHA's authority to penalize non-compliance. So section 1, we wanted to reference the OAR definition of the recipient of the contract and kind of clarify the language within subsection A through F. So I'll read through that. For a loan repayment recipient, we we removed that under OAR 40930 shall be considered in non-compliance with OARs within the full scope of the rule when the eligible provider participating in the program does the following things: fails to comply with the terms of the contract, fails to maintain employment at a qualified practice site for the duration of the contract term, fails to complete the minimum service obligation or does not apply or receive a suspension or a waiver of minimum service obligations that we referenced back in section 100, fails to practice through the contract term in a site designated to serve the underserved population if located in a community with a population HPSA score, fails to serve Medicaid and Medicare patients in no less than the same proportion as patients are served in the county or other service area as determined by the authority, up to a maximum of 50% of the eligible provider's patients, and participates in other programs requiring service obligations. And then we included the subsection 2, some language there that says that the authority may impose a penalty on an eligible provider receiving loan repayment subsidies in the amount up to the sum of. And here's where we did make some probably the most substantial change, I think, in this whole rule change. So we didn't change anything about the total paid from the healthcare provider incentive fund to the participant or on behalf of the participant for any periods of obligated service not served. However, previously, the penalty for noncompliance is $7,500 for each month of the minimum service period not completed according to the terms of the contract. We have decided, per recommendations with our DOJ representative, to change that $7,500, which is we pulled this information in alignment with National Health Service Corps noncompliance penalty. So this is where this information came from. However, we now have a lot of several loan repayment and loan forgiveness awardees that may not have as much of a debt load that we would be repaying. So that $7,500 for each month of the minimum service period not completed could potentially equal more than the actual award amount that they were received. So we felt that this was quite a high penalty for individuals. So we decided to modify that to $500 for each month of the minimum service period not completed according to the term of the contract, up to 10% of the total award amount. So we're still offering a substantial penalty for noncompliance within one of our incentive opportunities. But I guess we wanted to make it a little, we didn't want to make it more than the potential award because if they're not able to repay their award on top of the penalties, I think that would be really inequitable. You know, a lot of our providers could be in difficult places in their life, and things are just we just didn't want to have this high level of penalty at this point in time. So I'm going to pause there to see if anybody had any. I saw a thumbs up, which is from Patty. Thank you. But I just wanted to pause for a moment on that one because that is a bit of a change. Okay. So then section C, we did add, remove some redundant language. Interest on the above amounts at the maximum prevailing rate as determined by the Oregon Department of Revenue is calculated from the date of breach until full repayment has been made. We did remove that the participant may appeal decisions made by the authority based on based on our recommendations from DOJ, because we don't have the appropriate authority or language to comply with ORS Chapter 183, and it may not need to be a case hearing. So it was recommended that we remove that language. And then we so sections 3, previously the inclusion of that more specific language when to standardize non-compliance parameters to clarify OHA's authority to penalize non-compliance. We moved those down here under OAR so again, adding some OAR definition on the recipient and complying and adding in the clarifying of non-compliance information for loan forgiveness or scholarships under sections A through G, which I'll read through as well. So this states that shall be considered in non-compliance with the OARs within the entire rule when the eligible provider participating in the program, again, fails to complete their residency or training, fails to comply with the term of the contract, fails to maintain employment at a qualified practice site for the duration of the contract term, fails to complete the minimum service obligation, and does not apply for or receive a waiver under the section 100 around temporary suspension, fails to serve Medicaid and Medicare patients in no less than the same proportion as the patients served in the county or other service areas as determined by the authority up to the maximum of 50% of the eligible providers, patients, and participates in other programs requiring service obligation. So very similar language to loan repayment above. We did add section 4 that rewords the penalties for non-compliance under sections 3A and 3B all the way to G. So the authority may impose a penalty on, I lost my space there, on any provider participating in the program and receiving a loan forgiveness or scholarship incentive as follows. So these are all new sections. If the eligible provider fails to complete their residency or training, the eligible provider may pay the authority an amount equal to 100% of the funds received from the authority plus any interest on the unpaid balance as accrued from the disbursement date of the funds according to the terms of the contract. We are not an interest-free loan lender at the Oregon Health Authority. So we do feel like adding interest to a repayment is a reasonable request. The authority shall collect any penalties imposed under this section and deposit the funds in the authority's account established under statute 676.450. And then if the authority determines that an eligible provider participating in the program is subject to a penalty under this section, the authority shall issue a notice of proposed action as described in section 125, which we will get to here in a little bit, maybe. All right. I've kind of scrolled. So this information, let's see, where are we at there, Jamie? I looked away for a second and then everything went squiggly. So this section, we just kind of revamped for clarity of language and making sure that we had a section for loan repayment and a section for loan forgiveness and scholarships. So this is all the same information that we just moved a little bit higher above. So I believe that is all for that section. And I think that's maybe a good place to stop, so that we can leave time for public comment. Alyssa, do we have? Actually,
yeah, so on the agenda, we were planning on starting public comment at 12:15. So we do have about 7 minutes till then. And then if we don't have any public comments, I'm not sure if we have any members of the public. We would have an extra 10 minutes to get through more sections.
Okay. Well, we have 3 more sections to go. Maybe we can try to get through at least one more, if that works. Or, I mean, these are very, very minor changes. So why don't we go ahead and do that? So maybe we can have a pretty short RAC meeting in January. That's my holiday gift to you all. Let's go ahead and move in through section 130, or contributions to the Healthcare Provider Incentive Fund. The only change that we made there is a very minor grammar revision within this section from qualifying to qualified. So I'll stop if anybody has any comments about that. We're just trying to keep consistent language in determining whether it's a qualifying practice site or a qualified practice site, and keep that consistent throughout the rule revision. If no questions, we'll go into program integrity. So we did provide a little bit more information of revision of language through sections 1 and 4 that clearly outlines the program requirements for maintaining program integrity, including audits, post-review payments, and maintenance of contracts and financial records. So I'll go ahead and read through this language as well. The authority shall analyze and monitor the operation of the program and audit and verify the accuracy and appropriateness of all payments made under the terms of this program. Subsection 2 talks about the eligible providers participating in the program under contract with the authority and receiving payments from the authority are subject to audit or other post-payment review procedures for all applicable payments. Eligible providers participating in the program must develop and maintain adequate financial and other documentation as determined by the authority and in compliance with the eligible provider's contract with the authority. This includes records of all activities associated with the funds received under the contract, of all prerequisite and disbursement funds under the contract, and reflecting that the eligible provider participating in the program maintains employment at a qualified practice site. That an eligible provider participating in the program serves Medicaid and Medicare patients in no less than the same proportion of that patients is served in the county or other service areas as determined by the authority, up to a maximum 50% of the eligible provider's patients. So we wanted to make sure that that definition matches the rest of the definitions of eligible practice sites and providers practicing in a qualified practice site. Reflecting that the eligible providers practicing throughout the contract period in a site designated to serve the underserved population specified by HPSA type, if applicable. And then I don't think we had any, no changes to, we just renumbered everything. And then section 5, we included let's see, we capitalized carrier so that any overpayment made to the individual or carrier for the rural insurance subsidy incentive is subject to recovery. The authority shall take appropriate action and may redress payment errors or false claims for payment under the capital P program. So those were the only changes there. And I'll stop for comment or questions. And then boy, oh boy, if we don't have any of those, I think this is our last section. And we're getting there. So section 150 is about data sharing. Again, this was inclusion of some very minor grammar revisions within this section of rule, which I'll outline really quickly. The authority may not share data about eligible providers or students participating in the program, other than the purposes of planning, program evaluation, or analysis. Data may only be shared with agencies, offices, or contractors of the authority, the Oregon Employment Department, and a non-governmental entity not noted above, only with written approval from the director of the authority. So those are the only minor grammatical changes, grammar revisions to that section. And I think with that, I think we're done. I did want to note, we were going to include this in the third rack, but since we are through all of this, I did want to make a note, that as we went through the rules, we had our Pete Edlund, who is our main person at the Oregon Health Authority, did make note to us that use of websites as part of the definition process is not accurate. And so we wanted to make note of that. We have several sections that we are going to modify and remove the website address, and instead we will use current any statute or any I think provisionary any rule or statute that is tied to that definition instead of using website address. And any area in the entire document, it is recommended to us through our government relations department that any document or any change that we had from will should be changed to must. I think that was another change that we wanted to open that up to everybody as well and just notify. Those were two areas from our last RAC meeting that we wanted to share with you all, that we will be making those changes to the rules that we have currently in alignment with the best practice recommendations and what's actually allowed from our government relations team. So I wanted to also make note of that. We were going to mention that and discuss that at the next RAC meeting, but I think because of where we're at and how quickly we were able to get through everything, we will may not need a third RAC meeting. Does that seem accurate to Alyssa and team?
I wonder if for now we should continue to plan on that, in case when we do make changes to the website references, there may be an opportunity or a desire to maybe comment on some of those
Sure.
definitions. So it might be a short meeting, but maybe we should meet just in case.
Okay,
there's any
sounds great.
comments there. Yeah.
Sounds great. Okay. Well, Jamie, would you mind pulling up the PowerPoint presentation again so we can move over to our next section. So I think we can go to the next slide. With that, we will continue to hold our third RAC meeting, which is scheduled for January 16th of 2026. So any revisions that we made based on the comments from our government relations team, we'll make sure to include those in the full real set changes. And if you have any additional comments for that, you can absolutely make a comment on. And with that, I think going back to our agenda, we would want to open it for public comments, maybe a little bit early, or I guess a minute over. So we'll hold space for any public comments. If you want to raise your hand or if you like to put something in the chat, we're happy to hold public comment now. We also have a public comment period anticipated in late February or early March. And then keep your eyes out for our public hearing notice during the public comment period. We'll be going out. And I believe that's will be shared on the transparency website.
Do you want to hold space for public comment for a minute, or do you want me to jump into next steps?
Let's go ahead and hold space for public comment, and then if we have radio silence, then we'll go ahead and move on to our next steps, I suppose. All right, I'm not hearing anybody chime in. I want to give enough time, but there's also that awkward silence, and the possibility of ending a little early is always probably enticing on a Friday now afternoon. So I'll pass it back over to you, Alyssa, if you want to talk about next steps. Thank you.
Yeah, of course. So for those of you who were not here during the first RAC meeting, I did want to make sure you kind of knew it was coming up. But before I do that, I would like to remind you to please put your name and affiliation into the chat if you have not already done so. And if you are not a RAC member, please also make sure to put your email address into the chat so we can include that in our attendance records. In terms of next steps, Jamie, can you actually go back to the previous slide? Thank you. Like Jill mentioned, this is our second of 3 RAC meetings. We have our next scheduled on January 16th from 11 to 12:30 p.m. After the RAC meetings are over, OHA and ORH, the Office of Rural Health, will review the proposed rule changes and will submit a potentially revised version of the rules for public comment. The public comment period allows the public to provide written feedback on the proposed rules. And during that period, we will also host a public hearing to allow for verbal comments as well. And all input gathered as part of the public comment period will be part of the public record and may influence final decisions regarding the rule. Like Jill said, we anticipate this to start in late February or early March. I think it'll probably be early March. But as RAC members, you will receive notice from OHA prior to the public comment period. So you will be made aware of that and are welcome to participate in that as well. Next slide. In terms of immediate next steps, if there was anything you didn't have a chance to share today, you are also welcome to provide written comments. So after this meeting, I'm going to send an email to all RAC members with the link to a RAC meeting number 2 written comment form for you to complete if you would like. And we will have that form available. It'll close at 5 p.m. next Friday, December 12th. So please make sure to submit any feedback prior to then. And we will also have a different written comment form available for our last RAC meeting too. So if you aren't able to attend that last RAC meeting, you are still able to provide written feedback on the agenda items. And we will send the agenda out for that meeting by next Friday, December 12th. Any questions? Great. I'll hand it back to Jill to close us out.
Okay, great. Well, I wanted to extend my profound thank you. Thanks to all of you who participated in today's RAC meeting. We couldn't have done this without you all, and we appreciate the time that you set aside to listen to me work through and talk through all of these rule changes. We hope that they're for the better and clarity of understanding our program. So. As Alyssa said, please be on the lookout for a few additional emails with us, and we'll have our next RAC meeting for any tie up any loose ends and follow through on anything else that we're missing here in January. And I wanted to wish you all a very happy holiday season, warm weather, cold weather, whatever you enjoy. Thank you for your participation, and we will wrap it up a little early. And please don't hesitate to contact us if you have any additional questions, maybe not necessarily related to the RAC, but if you have questions about our program, we have staff at the Oregon Office of Rural Health, or myself, Alyssa, and Jamie are here to help support the conversation as well. So we appreciate you all, and thank you so much for your time today. Thank you.